Well, hey, welcome everybody back to the Clubhouse Chats. Today's topic we're going to be discussing is scapular dyskinesia. We got a couple questions from our last discussion relating back to tendinopathy, so we're just going to kind of round that up a little bit too. As we get into more and more of these talks, obviously some topics will be reoccurring, so don't feel bad, or if you miss a topic or you have a discussion of a previous topic that's been discussed before, we can always come back around to it. Don't worry about that. So we're going to talk a little bit more about tendinopathy first, and then we'll get into some different scapular presentations. If you are coming on, feel free to unmute yourself and ask some questions. And if you are just in the chat or in a noisy room, feel free to ask your questions in the chat as well. We'll get rolling here before too long. Hopefully some people start coming on a little bit more so. But just to go back on last week's talk, the tendinopathy, we had a member ask a question as far as it relates to how do you start describing time frames to your clients. And clients don't necessarily always have the most realistic expectations as far as time frames go, as far as when they're going to be back to the activities that they enjoy doing, or back to sport, or out of pain. And sometimes we need to be the bearer of bad news. And how do we approach that with clients? What's the best way to start that conversation? And just some things that we've found helpful talking about healing time frames for those clients. So I'll let you start off, Eric, and then we'll go here. Eric he sent me a nice visual picture, and I'm sure he'll get into this a little bit, but I got it. I can pull it up here so people can see it. I'll pull it up real quick, actually, first here. So I'll share my screen.
Yeah, I just like that visual. Obviously they're not absolutes, but I feel like it gives patients like nice visuals. So I pulled it up before. Actually, I just had a shoulder tendinopathy today that I just pulled it up on at like 9 o'clock. So
yeah,
she has a tendon issue. So I showed her, she had traumatic event. She basically she fell and had a severe, like, strong shoulder extension. She had bruising in the anterior part of her shoulder, pain right over supraspinatus insertion. So, I mean, you're looking at possible with mechanism of injury. It's been 6 months. She's much better now, but like it may be partial tear. So I went over tendon with her. Truly, it's not lacerated where it's completely gone, but technically I would say that if you have 50% tear and you have a little bit of that, there is like a partial laceration. So I just explained to her, she's at 6 months. That's how tendon can take that long to heal. We just don't normally think of it in that manner. Usually if you relate it to similar to hypertrophy, so if you explain to somebody you are not going to go into the gym for 2 weeks and look substantially stronger with muscle mass, it kind of correlates the same with as far as like tendon healing. It takes a while to see like a true actual structural change. I think you can see changes in pain much quicker than you can see true changes in like internal healing. And it's important to then, like you said, Greg, try to relate that. And how do you express that to them and have them understand?
Yeah. Are you able to see my screen share here, just so people can see this? Okay. Yeah. So here's the visual that Eric sent me. I think it's definitely useful. And this was, I assume you got this off of Instagram by Caleb Burgess here. So
social media learn. Yeah, I like it.
So certainly having something like this in your clinic can definitely be helpful, just so people can kind of see it. If you want to give it as a handout for them to take home, the big thing that it does is it sets expectations. So, I mean, you may be doing all the right things, but if the client feels they should be getting better quicker, they may not be bought into the whole process of things too. So the more you can set expectations early on, the better compliance you're probably going to have. So I'll link this in the notes section of this talk, just so people can have it, but feel free to make your own, or give Caleb here some likes, follows if you are on social media. But the other thing too is I like how you talked about relating it back to hypertrophy. I think a lot of people can visualize, or just not necessarily visualize it, but they know what you're talking about when you say muscle doesn't grow. within a week or so, but your pain can change too. So that can be the other factor when you're talking to them, is when they see these time frames, they all of a sudden get very, very depressed. But when you talk about, your pain doesn't necessarily mean it has to be going on this long time frames. Your pain may stop beforehand, or it may linger on longer than that too. So there's things that we need to do to make sure that that doesn't happen. But giving someone healing.
Greg, you cut out.
You a little bit more ammo or more power to kind of talk to them, even if they are feeling better, to just slow the roll a little bit, slow down.
You just cut out for a minute. I don't know if it was just my screen. Maybe not.
Okay. Yeah. No, the big thing, just in case it was missed, the big thing there was just making sure that if someone is out of pain a lot quicker, because pain doesn't necessarily have to go along with those same time frames, it can be shorter or it can be longer, is to make sure that they have that understanding before anything starts, so that, if they are out of pain and then they want to get back to their activities full bore again, it gives you something where you can kind of slow them down a little bit and say, this, how long it's going to take for it to actually heal. Just because you're out of pain doesn't necessarily mean you're out of the water yet at this point in time.
Yep.
Something I like also saying too with this is, again, kind of the more you can set expectations with them, the better. So with any type of tendinopathy, it's usually not a steady recovery process. There's a lot of ups and downs to it. So something I usually tell them is to, think about your pain levels almost like the stock market. Is we want to see a general trend heading upward, but there's going to be some daily fluctuations that happening. So we need to be mindful of them, but understand that there are going to be some changes that happen on a day-to-day basis, but the general trend on a week-to-week and especially month-to-month basis should be definitely noticeable changes.
Here's something just clinically too. You'll notice, I feel like if you break it down in percentages, if you take someone who, let's say, just cuff tendinopathy, bringing them from where they're at 0% to 80% improvement can be done much quicker. That last 80% to 100% takes a long time. So I may find that if I have somebody, let's say, spanned out over just arbitrary 3 months, at first I'll be seeing them more frequently maybe, and then I may get to where it's 1 time a week, and then I'm dropping them to where I'm just progressing home exercises because it just takes continued loading over a period of time. So that 0 to 80, you can make more change as far as manual hands-on techniques, reducing pain, and then long-term, they just need to exercise. So you may break them to where they're coming once every 2 weeks if you have that ability, because that last 80 to 100% takes a while.
Yeah, that brings up a good point too, because usually when people are, getting 80% better, they're thinking they're close to being completely better, and they're expecting that timeline to still be the same, and that last 20% to happen just as quick as the first 20%. But they also start slacking off on being as consistent with exercises at that point in time too. So not only are you at the hardest part of your recovery stage to get at full capacity back, but people tend to slack off a little bit more too. So it's just something to kind of keep talking to people about, and keep reminding them that they're not out of the woods yet.
Yeah, to avoid regression. Yep.
Cool. All right. So the big topic we had today that we were going to get into was scapular dyskinesia, whatever you want to call it. And we're going to talk about a lot of different things. I think a good place to start is just how to assess it and what it is. So I'm going to share my screen here quickly again. Just to show visuals. I know a lot of people are probably already familiar with it, but this is kind of what we're talking about here, where you got the inferior medial border prominence, and then a lot of the presentations seem to be similar to where you have this flatter T-spine with the medial and medial and inferior border prominence, and then when you perform, say, like a abduction raise or a flexion raise, it becomes even more pronounced, or there may be some aberrant movements that occur there as well too. Is that pretty much what you're seeing clinically too there, Eric?
Yeah, just any kind of aberrant extraneous movement, typically an deflection or abduction. A lot of times actually too also, and I'm sure a lot of people would agree with this, you'll see it more when they lower actually than when they raise up. That controlled lowering is where you get some of that dyskinesia to occur, more so even than just raising it. But yeah, same concept.
Yeah, it definitely does seem to be with the lowering. The other thing too is checking it with load. So if you look at a flexion or abduction, scaption, whatever plane of motion you want to utilize there, it definitely, if you put even like a 2-3 pound weight in their hand, they may not necessarily demonstrate any of that dyskinesia when they move through the concentric or eccentric portions. But if you put a 2-3 pound weight in their hand, all of a sudden now it is pronounced. So
yeah, you'll see more compensations when load is placed. That's with anything.
Yeah, and it makes me wonder too, like how significant it is though, because I mean, if you give an athlete 2 pound weight and hey Dan, what's going on? If you give a 2 pound weight to an athlete and then it changes their scapular kinematics drastically, I mean, that's such a minimal amount of load compared to everything they do in life, not just sports. It's odd that it would cause that extreme of a difference. I don't know what to make of it, but it is just weird that only 2 pounds of, you would think the more extreme load you go to, you know, it would gradually get worse and worse, but not necessarily the case.
Yeah, it's interesting. I agree, especially if you have a somewhat decently strong individual, and then you also bring up the point, if you give them more load, will they actually require more stability? And then their dyskinesis will actually reduce when you give more load because they're pulling in more like stability through the core and through the scap stabilizers. So yeah, it's interesting. Yeah, not that always happens, but yeah, I don't know. That's such a gray area. This is not black and white. So
yeah. Well, that brings up the discussion, you know, is if someone's not in pain and they have this, you know, what percentage of people have this to begin with too? And then, you know, if they're not in pain, is this a reason for why someone would be in pain, or is it just a factor that's always been there, and it's not related to their pain whatsoever too? I don't think there's any clear answer to that as well.
No, it's tough because there's some research that shows that you can find individuals that it's like a feed-forward mechanism. Greg and I have talked about this. So they had no dyskinesia or dyskinesis of the scapula. Once they have pain, then they have dyskinesia. I hate that word. Dyskinesis, whatever, of the scapula. So pain is actually a feed-forward mechanism to cause their shoulder girdle and surrounding muscles to not fire in coordination appropriately, and then they secondary get that. So that's the whole chicken or the egg thing. It's, yeah.
Okay. Yeah. The other thing too, again, how much it really matters in someone's symptoms, who knows? But it's definitely probably a component of looking into as far as why that may be occurring. One, because they're in pain, or two, you know, if you clear up pain and it still persists, you know, what could be going on there? Some different things, kind of talking on a very more of a basic level. I mean, we're all familiar with your cuff exercises, I-Ys, T's, W's, where you're addressing the scapula musculature in that fashion. Something too that I've noticed is if you add some type of closed chain component to it, it can improve the activity. So talking about that flexion, scaption raise again, if you put someone in a doorway and where their opposite hand is stabilizing themselves into the doorway and just getting maybe some of that proprioceptive input feedback, and then you have them go through that raise with no load, with load, whatever you noticed it with, sometimes it improves. Not always. Sometimes it definitely does, though.
Yeah, or like if you have a foam roll across the wall horizontally and then doing a Y motion up the wall and just, yeah, again, that proprioceptive feedback. Or if we get into some exercises, I would say my favorite is the quadruped with the furniture sliders on the hands and then bringing the arm up forward into flexion to get that serratus anterior to fire. So
Right.
yeah, some feedback, some proprioceptive feedback through the arms.
Yeah, those are two big ones actually that I like, which is the wall slide up the wall, kind of in your Y fashion, and then like you said too, in the quadruped, where the other thing too is say you notice that in quadrupeds, so someone's elbows extended, arms extended, and they're on their knees, obviously, you could actually still notice that aberrant motion still occurring in that position. Oftentimes it does help though, because the hand's in contact with the ground, being on the valve slide, and then in the top range of motion you lift off. But I have still noticed it in that position before too, and then sometimes if you regress somebody's body position a little bit further to more supported, so even onto elbows, I've noticed some people who demonstrate with that dyskinesia with their elbows extended, and then you drop them down to their elbow, have them perform it, and actually clears it up sometimes.
Yeah, you're just reducing extra components, like taking out the elbow and like wrist out of it. I agree with that. Greg, would you?
Thanks for joining. Yeah, go ahead, Eric. I'm just reading a question that we had here. Go ahead.
I was just going to ask, it's not confusing, but it's a little bit confusing. Could you share a link with a video or something to the quadruped valve slide one?
Yeah.
Or like in the show notes or something?
Yeah, I can put one in the show notes. Yeah.
I don't know if you're able to do that or not, but I feel like that one is huge. I feel like it's not used a ton. Maybe it is, but yeah, I feel like that's one of the best ones.
Yeah, I don't know. There's the SFMA, and FMS guys are big on it. They call it the reach, roll, lift. It's the same kind of concept. Most of the time they don't use the valve slide. I like the valve slide idea just because it slides a little bit easier, but reduces friction. But so what they'll do, and it's kind of the same thing we're talking about, is your most supported component would be is on elbows and knees, and then you perform that reach into the Y, but you're supported during that reach, and that you're getting that proprioceptive feedback from the ground. And that proprioceptive feedback from the ground, I think, is big. Hey, Vinny, what's up? Feel free to put a question in the chat when you got some time. Glad to have you here. But yeah, so that component, and then what they'll do is there's assisted and resisted versions of it as well too. So similar to a bird dog, you could be putting a TheraBand in someone's around their ankle or around their foot, and then having them reach through resistance in that diagonal fashion with the valve slide there too. So that's a way to challenge them a little bit more so. And then if you needed assist, it's a little bit more of an elaborate hookup. Assist would be on the lift off portion, and you could put their hand in like a band that's attached to like a squat rack coming down, and then it gives them some assist to kind of lift the arm up off the ground, which may help with your low trap if someone just has some difficulty there.
Yeah, those are good progressions. Basically, just taking every exercise as it's normal. What is the hardest, most challenging exercise that someone can do correctly? So again, if they can active range of motion, it looks fine. Add in resistance, add in some load to it. So to progress that.
Yeah. So Dan asked a question here, and feel free to chime in again with a follow-up, Dan, if I'm getting this wrong. But just to kind of summarize it, it's is there a big difference between open and closed chain exercises that we utilize, and if so, kind of what's our go-to between the two? And I think we kind of touched on it here just a little bit already, that closed chain is probably your easiest place to start, just with that proprioceptive feedback. and just getting the movement down and trying to take away some of that aberrant motions that may be occurring from motor control in a variety of different reasons. So having that proprioceptive input from the ground is helpful to just start going through some active range of motion. But then, as we mentioned with the quadruped valve slide there, or the wall slides, I think the extra component, the next component would be to get a lift off there. So then you take them into the open chain and still have control, and you may have them isometrically hold that position for a little bit too, to just drive more motor control into the area as well. I don't know what your thoughts are on that as well too, but I'm usually starting with some type of closed chain exercise, then moving that into a closed chain, which switches to open chain, and then trying to add some open chain exercises after that.
Yeah, I would agree. It's almost the same as any concept in rehab, like SFMA. So if you want to regress things, the least aggressive position is going to have the most points of contact. So if you look at supine is a much less aggressive position or threatening to the body than standing. So if you're in quadruped, you have 4 points of contact, or essentially 6 if you also have the feet on the ground. But doing movements through that, the body, it feels more comfortable, and it can kind of move things and coordinate patterns in a better fashion than when you start removing that contact with the ground. So that kind of just summed up that I agree with you.
Yeah. The other thing too is another way to add more assistance to it. So instead of say someone's in quadruped again, if you, instead of dropping them down to their elbows, what you could do is, if you have like a stability ball, physio ball, put it at the wall and have them push their butt back into that ball. So it's their butt's pressing the ball into the wall, and that gives another point of contact there. And also that you actively having to push back a little bit may activate some serratus in the opposite side, as well as some core stabilizers as well too, which may have some type of keyboard mechanism that helps out with the whatever exercise you're doing, in particular the Ys we've been talking about. Does that make sense what I was talking about there, Eric? Did that kind of,
yeah.
I don't know if have you ever used that before?
I have not. It's a good concept though. I like it.
Yeah. So, and then what about, so if you are, when you start transitioning to open chain, what are some of your go-tos there?
Again, I guess I try to break it down and regress it a bit and see if I can add more points of contact. So I will then get them in, for example, it's not real aggressive, but have them in standing, like the Y up the wall. So you may have that, and then you may progress that with a foam roller. So you're giving us some assist, remove the foam roller and have them with the lift off, and then you can take that another step and add a band around the wrist. So then you're adding some resistance too. So figuring out just different ways to coordinate exercises in that same fashion, slowly taking away points of contact to progress it.
Yeah. The also too is you can have one side of the body in closed chain, in half kneeling, whereas the other side of the body, the arm is moving in the open chain too. So that's another way to utilize points of contact, where maybe it's not the working arm that's in closed chain, it's the other opposite side.
Yeah, there are a million different ways to go with that.
What about, so Dan asked a question, what about, different implements? So TheraBands, weights, do you notice, so with the TheraBand, there's going to be increasing resistance the further you go into the range of motion. So if you're doing a Y, obviously at the top position of the Y, the resistance is going to be a lot harder than, say, mid-range, whereas a weight is going to be more consistent throughout. Anything you've noticed with that?
No, I would say that you're starting to miss the forest for the trees, or the tree from the forest from the tree. Yeah. Anyway, I feel like if you're breaking it down to that extent, you may. Then that's just my viewpoint, though. As far as breaking it, you're almost breaking it down too much beyond what you even need to, as opposed to just teaching the gross move. Miss the forest for the trees. You got it. As opposed to just progressing the movement, and then you're almost breaking down a movement too much that maybe doesn't need to be broken down that much. Starting to kind of simplify it a little bit, actually.
That never really thought about this too much, but so breaking things down too far, how many times do you, so we noticed the dyskinesia happening more with the eccentric lowering. How many times in daily life are you really eccentrically lowering your shoulder? Most of the time you're pulling, and that goes into the foundational, movement patterns, push, pull, vertical, horizontal. Many times you're not just lowering your arm to the ground. And oftentimes when someone's in pain or has a tendinopathy scenario, a lot of times that eccentric lowering is bothersome and it's provocative in the early stages. So oftentimes I just tell them to pull their arm down. You activate a different muscle group. Maybe there is some different kinematics that happen at that point in time too. And it oftentimes decreases their pain. So it's interesting because, many times not many times in life are you eccentrically lowering your shoulder.
Yeah, agreed, unless it's for like a weightlifting purpose. I also agree with you with changing the kinematics of the way the shoulder works by doing, for example, this is off now, but if you have somebody with a shoulder impingement reaching overhead, you can actually have them do an eccentric lat pull down, so they're raising it up, and they may have no pain with that. So I don't know, that's kind of off topic now, but yeah. Getting back to it, I guess I would say, is there scapular dyskinesis to that extent really my number one concern, or are there other dysfunctions that I need to address first, and then the scapular dyskinesis will then kind of follow through and it will start to like heal itself? So I guess I don't overthink that dyskinesis to that extent. Okay.
Now bringing up some other implements. So like kettlebell is a big one that I like to use in the clinic. Dan's talking a little bit about here in the chat. It's a couple things you can do with that. I think most people are familiar kind of with the bottoms up and just what a kettlebell is. The bottoms up and just using the kettlebell seems to be a nice implement to use. Reason being, the kettlebell, like if you're just doing an overhead press, the bell being behind you, I think it has some type of impact on things. Just kind of where it's loading the shoulder, and maybe it improves activation of the backside of the cuff. I don't know, but it seems to, if you were to compare the kettlebell versus just a dumbbell overhead press, it seems to make a difference. As far as what I've noticed with.
I would agree. I think that those are, it's only anecdotal. I don't think there's any research on EMG for kettlebell, but I would firmly agree with that.
I've noticed it as far as pain wise too. A lot of times people it feels better to use the kettlebell for a press rather than a dumbbell. There's maybe some kinematic things later that in other chats we can kind of talk to, that's getting off topic a little bit, but the bell just being a little bit more posterior has some type of impact. I really feel. The other thing with the bottoms up, the unstable component, that could definitely challenge the individual enough too, to where all of a sudden the eccentric lowering now is looking a little smoother, not having so many aberrant motions with it as well.
Yeah, unless it's too excessive.
Right. Yeah.
But yeah,
you easily get too excessive with that. I think some people tend to try to go way too heavy with those. Okay. The last little bit about the talk here today that we'll get into, unless anybody else has got questions. So if you have questions, put them in the chat, or feel free to unmute yourself and come on and ask a question or two. I'd love to have your guys' input on talk. Talking, you mentioned this, I think it's key to don't go too far down the rabbit hole, or don't miss the forest for the trees, because you can get too complex with your treatment algorithms or your treatment process, and not everybody needs to be in an elaborate program by any means. But if we consider the scapula and some aberrant motions that it may be having, you do need to kind of think about the rib cage and what lies underneath of the scapula. And people will argue, is it really the scapula that's moving away from the rib cage, or is it the rib cage that's moving away from the scapula? And I don't know that there's necessarily conclusive information on this. All that I know is, you know, there's both sides of the equation, and both sides of the equation seem to be helpful for people too. So we've been talking primarily rib cage here. The other component now is, you know, what about the rib cage moving away from the scapula? So if you consider someone just, we're taking postural presentations here just from the start to kind of look at tendencies. If you're looking at someone from the anterior and you see a bilateral rib flare, lower rib flares, what you're noticing is that the thorax, just via position, is moving more anteriorly. So naturally, the posterior aspect of the thorax has to be moving forward too, for that to occur. Unless you're getting true expansion and recoil of a rib cage during respiration, which if you're just looking at someone statically and you're seeing a very prominent lower rib cage in the anterior portion, you're assuming that it's this is their tendency, and then you can, you know, ask them to breathe and kind of push down on the ribs and see how well they perform respiration in that fashion too, and just see if anything changes or how much difficulty they have with that. But I think that's an important aspect of the looking at it too, is just, is the rib cage moving away from the scapula? Any ideas on that, or questions on that, Eric?
Yeah, so if it is, how would you progress it from there then, once you have that assessment and you notice it is flared a little bit anteriorly? Where would you go from there?
Yeah, so this ties back into what we were talking about. If you're in the closed chain, having someone push, if you're pushing into the ground, you're driving the rib cage backwards or posterior. So maybe there's another component, not necessarily just proprioception, that of why the quadruped position is so useful, is because you're having someone push. One, yes, it's serratus, but two, you could be driving the rib cage backwards, which now when you move someone to half kneeling or you know, standing, they're not necessarily, it's not as easy to get the rib cage to move backwards. So what you can do is you can, this happens over a lot of different you know, activities, and again, working on things on a lower level. But when you're having someone breathe in and out, when they exhale, the rib cage needs to drop down, in, and backwards. And then the key on the inhalation there is where you focus on getting the breath cycles. So instead of allowing someone to inhale again and allow the lower ribs to flare, we want to try to secure them down and get inhalation to the low back, posterior mediastinum, and then kind of radiating up into the chest. So think about like a glass filling from the bottom up, where the air pressure is filling from the bottom up, but we're trying to drive air pressure in different areas that maybe they're not getting air pressure just through normal respiration, because that's an autonomic thing that happens. So doing that with your quadruped activities, because that's probably the easiest place to teach something like that too. Once they get those basic quadruped movements down, so you're not adding so much complexity at once, then incorporate a little bit more complexity with the breathing component aspect of it too, so they have something to go back on when you move them to standing or half kneeling, where it's okay, you know, let's get the lower rib cage set, breathe, you know, low back kind of up into the chest, and then go from there. Does that help you out, Eric?
Yeah, no, I know what you're saying. So essentially, like if they were in quadruped, you could have them focus on, while they're doing the same exercises they would without breathing, they could also focus on like breaths going into the back. Is that, they would focus on breathing like deep into the back, that way they're not exhaling or inhaling and it's going anterior. Right. So that would be your verbal cue, basically. Right.
Pretty much, yeah. There's a lot of intricacies to this, and we can definitely go further into it in other talks too, or even a little bit more today. But so number one, how do you assess it? Kind of what Dan's getting at here is one, you're looking at just resting position. And so if you have someone supine on the table, a lot of times you can get a feel for what the anterior lower rib cage is doing. And then if I share my screen, on the back side of your patients, a lot of times you'll notice this like flatter T-spine here, or here too. So with the reach, not only are you trying to retract or push back the scapula, or push the rib cage back towards the scapula, now you're trying to get them to hold that position and then breathe and have expansion into that position there too. So essentially with the activity, you're trying to move the rib cage back towards the scapula. And there definitely could be some asymmetries left to right. But if you're just considering a bilateral presentation here, that two-arm reach where you're pushing the rib cage back towards the scapula and then trying to drive expansion of airflow there too, may be helpful as well. To get into your point further, Dan, if you're looking at spirometry, how much someone's able to exhale. A lot of times you'll find that people have you don't necessarily have to use a spirometer, but it's a measuring tool, so you get some numbers with it. But having someone see how long they can perform an exhale for, and a lot of times you'll see people who only can perform exhales for about 5 seconds, even after a pretty decent sized inhale. And that just tells me that you're probably not getting all their air out. And you should be able to exhale longer than you can inhale. Well, I take that back. You should be able to perform a full exhale. There's something called, it's a breath hold test, and it's just seeing your tolerance to CO2 buildup within the system. And you should actually, according to that test, you should be able to exhale for somewhere of about 30 seconds. And, it may not actually last for 30 seconds, that full exhale, but then whenever you get all your air out, you should still be able to hold your breath without taking another inhale. And that total time period between an exhale and then holding your breath actually should accumulate to 30 seconds. And if someone can't do that, the further they're away from that, the more you're thinking kind of a hyperventilated state. Now, what you could do with that too is you could push down on one side of the rib cage. So if you're thinking there's some asymmetry side to side, you could say, let's put pressure on the left lower rib cage and push down there and have them perform that same test and then compare it to the right side. And you may get a large difference side to side that you may notice as far as someone's ability to get air in and out of. And that could be influencing some asymmetry side to side differences that you're noticing too. But as far as numbers go, I don't have any. The breath hold test is meant to be a bilateral test, so I really don't know what the numbers would be if you tried to do something unilateral. I do go to it sometimes, but I'm just looking for a bigger asymmetry. If there's a large asymmetry side to side, then that's when I'm thinking, okay, maybe there's something kind of to it there. But
that makes sense. So you're just taking, basically, to sum that up, because I know that goes down an entire, you could talk about that for probably 10 hours. Basically assessing to see if there is an anterior rib flare where they're coming up, and then a quadruped focusing on breathing, the ribs kind of pushing back, and then you breathing with a deep breath into the posterior aspect of the thorax.
Yeah. So, I mean, I would start with the low-hanging fruit, as we talked about at the beginning of the talk, is, what's the easiest place to start with to try to get some type of result? And then sequentially go more and more advanced as you need to, and as they have competency over it too. Because a lot of times just getting someone, to figure out a reach can be surprisingly difficult for people who don't have a ton of motor control. So, don't add too much in at once, I would say.
Yeah, I agree.
if anybody has questions on that, because I know it's getting in more and more deeper into things. I know a lot of people like getting into that sort of depth. So if you have more specific questions off of it, it helps drive my conversation as far as what I'm trying to talk towards, as opposed to just kind of going over basic concepts too. So talking about certain presentations that you notice in the clinic are also useful. Because that it just helps drive more specific getting into the conversation. But that's definitely a good place to start for a lot of people.
The other thing is, and I'll just say, this is kind of common sense, but I'm going to reiterate it. We often try to come up with like fancy exercises and stuff, especially when you get something like a little bit more complex, like scapular dyskinesia. You can never have too strong of a rotator cuff. Your external rotation strength can never be too strong. So, I mean, don't miss out on a lot of that stuff for just some of the fancy. Obviously, you need to add in some scapular, like some upward rotation work, try to get that more fluent. But don't forget, like, your hardcore external rotation strengthening of your different types there, too.
Yeah, and you'll probably hear us say this time and time again on these talks is you know, how long has someone been experiencing these symptoms, too? You know, if someone's had some symptoms for a long period of time, you know, going on years, and they've probably been to health professionals in the past, and they've done the standard cuff strength exercises that we've done before too. That's where the subjective portion becomes helpful for you too, because you know what they've done in the past, you know how long they've been experiencing it, so you know how quickly maybe that you want to dive into something more complex. Because in certain scenarios where nobody's had pain before, you know, they really haven't addressed the low-hanging fruit, you know, start with that stuff first. Don't get more advanced than that.
Yeah. And to answer Dan's question, I feel like 95% of patients have no idea that they have anything crazy going on with their scapula. Most of them have no idea that it's moving weird. And honestly, if you try to explain it in depth, you're just going to lose them. So I'll just say maybe it's just not coordinating right, or it's just not moving quite right. We'll just adjust that, work on some strengthening. Most of them usually have no idea that anything's going wrong with their scapula. I mean, it could be winged out to the max and they have no clue. Or they'll just say, oh yeah, I just noticed that. It's not usually of concern to them.
And that's why the position matters so much too, is because if you're picking them into a too difficult position and you're really trying to give them as many cues as you possibly can, or even tactile cues with your hands, you know, say do this, do this, do this. A lot of times people can't conceptualize how to do that. So if you put them in a position where they can succeed, then it just kind of happens. It's more of a natural progression to things, as opposed to, you know, spending 15 minutes trying to cue someone into this perfect position that never happens, and then you're kind of up a creek because now they don't have anything to work on at home either.
Yep.
Cool. All right. Well, I want to thank everybody for joining in today. Getting more and more people coming in, and always feel free. Like I said, there's areas to add additional questions. So as your week goes on, something may pop up that you didn't think about here on the talk, and feel free to submit the questions there, Facebook, wherever you may have, and we'll get to them, we'll answer them, and it'll just kind of keep getting more discussion rolling, and we'll keep going from there. So thanks again for everybody who showed up, and we'll see you next week. See ya.